And I ask you to stay there
Okay.
and also get Jeff, Doug, and Dina to come for the panel you've all been waiting for. It is extremely difficult to get the IRB and regulatory right for this kind of networks. So that's why I thought of the panel discussing some of the difficulties that we had had.
Okay, right. So, all right. So Jeff is not here. So I said I'd fill in, though I haven't really seen his slides, but I think it'll be okay. Okay, so we're part of this IRB group that Jeff leads, and we're trying to figure out ways to streamline the IRB process for P-Scanner. And each institution has a different policy around this. And really what we want to do is identify opportunities where we can make things easier, both with regard to paperwork and also with regard to less onerous review. And so that's what we've been researching. I think today we're going to talk about IRB share and Veterans Administration coordination. And now we're on to my slide. So, one thing that we've identified as a way to streamline IRB is something called IRB share, which was, how many people are familiar with IRB shares? Okay. So IRB share was developed as part of the CTSI initiative to kind of bring clinical trials back to the U.S. hopefully, because it's very difficult to get IRB approval here. And I think it's a really interesting idea. So it's actually very simple, and it takes sort of baby steps towards streamlining IRB. The basic idea is that instead of trying to get all these different institutions to have trust and rely, or to cede review to another institution, or to have some common format, if you've ever tried to do that or talked to your IRB about doing that, they're very reluctant to do that. So IRB share is this idea that you still would get approval through your local institution. So any P-Scanner project, for example, that would be conducted at many different institutions would use its local paperwork, but all that paperwork would be uploaded into IRB share. So if UCSD wanted to propose a study, they would upload the UCSD paperwork to IRB share. And since USC is also a member of IRB share, they would be able to go on to IRB share and look at what UCSD's IRB said about this study and who to contact to ask them questions. So it reduces the amount of detective work that the IRBs have to do, and it reduces sort of this the repetitive aspect of multiple IRBs, where UCSD IRB, maybe we have to answer a question, then we'd have to answer that same question to the USC IRB. That's all documented in IRB share. And then the second thing about IRB share that is interesting is that this shared review site, there's a lot of contact amongst the different IRB share members, and some of them have developed cooperative agreements that have grown out of IRB share. So there are several organizations that now only require, if an IRB share member uploads an approved study, then all you have to do is upload a 2-page IRB application that's this kind of standard IRB share application, and then you can get approval. So right now, the way P-Scanner is set up, we have this trust and rely for the UCs. We have the VA, and we're going to talk about the VA and its relationship to IRB share. And then we have the USC partner clinics that are the scanner network. And USC is a member of IRB share. UCSD is a member of IRB share. We've talked to the IRB share people, and they're interested in getting more UCs involved in IRB share. Would like us to help with that if we're interested in pursuing this. So that's IRB share, and I'm going to turn it over to Doug Berman.
Sure.
Okay.
And I was just going to talk a little bit more about some of the pros and cons of IRB share and where it sits today, that it does allow sharing of information about protocols and really prevents the IRBs from having to go through the same questions time and again, and the other piece of it is that right now it is limited, but they are looking at ways to extend the service. And I think as soon as during the month of October, they're planning to look at going further. I mean, right now it only really supports the initial reviews without updates, amendments, or continuing review, and that's one of the big limitations that UCSF's IRB sees here, and that not all of our members are institutions, but that some are. It does support scientific review, but does not act as an IRB. The IRB still is going on record as accepting the protocols themselves. So what I think this means for the P-Scanner project and for groups like ours, or particularly for the UCs where we are looking at trust and rely, that we still need to have one of the IRBs in the trust and rely space agree to be the IRB of record, and then we can trust and rely that, but that the P-Scanner, or pardon me, the IRB share to one IRB to all the other IRBs probably isn't as transitive as you might hope it would be. And I think that the individual institutions aren't going to accept that right now. But that if we do have one going on record, that would probably cover us. That's control I've got. And I'll turn it over to Dena.
Thanks. So I think Doug just, and it's been alluded to before, that VA is not a member of IRB Share, and unfortunately Jeff Shennett couldn't be here today to talk about some of the issues from the top-down standpoint. I think what I have to offer up is kind of a bottom-up or test case approach to this, and Carl Stepnowski and I at the VA right here across the street have been working on IRB submissions for part of this project that Kathy Kim leads, related to the use of RAND as a site for expert panel discussions. So what's interesting about this part of the protocol, and as I say, this is almost a test case presentation, not the whole P-Scanner project writ large, but a smaller test, is that it was not actually deemed human subjects research at other institutions, but by VA San Diego, the expert panels are currently being discussed as a human subjects protocol. And the issues that are raised kind of from the bottom-up approach, at least at our VA, any project where a patient uses a computer with an IP address, that is actually considered one of their patient identifiers. And they're not allowed to use email addresses as part of any kind of human subjects protocol. So those are issues that are local policy, as I found out this morning, not national VA policy, but certainly policies that we have to have some respect for and negotiate about as we try to go about this kind of research, especially when those identifiers, if you consider those as identifiers, are going to be used off-site. So I think this is also being addressed through a number of national conference calls. I've been on some very interesting discussions with the PCORNet ethics group. Carl Stepnowski participates in the regulatory calls. And so those are being discussed as a very high level, but for the immediate purposes of what we're trying to accomplish, of course, we are looking at local IRBs for a lot of these issues, and so we're going to face these at local sites as we go forward. So, take questions.
Anyone has questions?
Thank you for that really interesting presentation. One thing I think P-Scanner could take a lead on is defining stakeholders as not research participants. I think there's really a danger that stakeholders, patients, caregivers, policymakers in your hospital could be considered people that need to provide informed consent when in fact they're really just your co-investigators. And I think it's
Right.
important for us to help other IRBs understand
Yes.
that. Was wondering if you have any
Yeah.
comments.
No, I mean, I actually had this discussion with the co-chair of the VA IRB last week when I said, I'm going to a meeting across the street with a whole bunch of people in a room and we're going to talk about research. Should I sign something before I, walk down the hill? Because some of this rises to that level. You should be allowed to talk to other people about things that interest you, and that's not necessarily a human subjects issue. At the same time, I do have respect for what for the line that the VA tries to walk. They have been very forward thinking in terms of a lot of the issues. I think when we heard about Vinci yesterday, you have to think that is a very ahead of the curve kind of thing. And yet at the local level, they have a duty that they sometimes feel, I think, more cautious, perhaps, than other institutions when it comes to any use of patients as part of the stakeholder group.
Right. Any other questions? Yeah, so the experience so far has been very interesting, I would say, in
That's a
trying
good
to
word.
put everything together. I mean, it eventually happened. This study in particular is that Delphi online, there were no risks involved. And I think we need to think about, again, thinking more advanced about certain things. And the reason we have certain VAs is because we do need to recruit the patients and the stakeholders from each one of the sites to be representative. So I think it's very important, again, to discuss the issues that we have and how we're going to work around those. And I think IRB is always an interesting entity. Sarah has a question.
So just a quick follow-up question. Do the IRBs talk to each other? I mean, because I'm really struck by that schism between, didn't think it was human subjects research at all, and how are we, and I'll say we, I mean, how are we going to,
Right.
move forward productively, and is getting the IRBs, to talk through these things one possible approach?
Right. I mean, we actually did a kind of grassroots version of IRB Share in that we took the UCD determination letter and we submitted it as part of our IRB package, which is essentially IRB Share on a local level. And I think for any of us who do this kind of, anyone who's kind of done this kind of thing, it's a fine line because you want people to feel as if they're still being allowed to make their own determination. So I can tell you 99 people decided that this wasn't research, and all you have to do is say it's not research and it'll be okay. And that might either make you feel like, as Jason just talked about, that might be the nudge in the right direction, or it might make you feel like you have to take a closer look because you don't necessarily want to walk over the hill with all the lemmings going that way.
Well,
And
and
there's
I think-
Jason's next study.
I think that the UC Trust and Rely, I'm sorry.
I'll be a hero if I do that study, right?
I think the UC Trust and Rely is also an example of places where they've started to work together, but that took years to come together and a lot of trust building, and ultimately they all report to the same office of the president, and they all are under the same regions, and it was really hard. I think it took a while to come to the place where they felt they could do that.
Yeah, I mean, the reason I asked is because I went through a similar thing with the HMO Research Network, where it wasn't until we got all the IRB administrators in a room to both socialize and strategize
Right.
that we started to see willingness to take a look at different models.
Did that sort of come from the idea that they were all overwhelmed and that they could see their work getting easier?
Yeah,
by
yeah. We
working
actually
together?
did studies of how they looked at the same study in a different way, and some said it was expedited, some said it was exempt, and some put it through full review. And once we eliminated that variability, they started to think about
Yeah.
what might change.
Great. Let me optimize here. I know Jane has a question, so Kathy can start coming up while Jane asks that question.
So as chair of the pediatric IRB here at UCSD, we are constantly trying to offload our agenda with things that we identify as QI, QC projects. So we would be thrilled to offload this from our agenda. But I think
My veterans are all over 18. Sorry.
But I think what that represents is that there is very little consistency across IRBs, and no, we don't have a forum where we get together. And I had hoped that maybe the CTSA would be something that would address that, but that hasn't happened. So I too am frustrated by the lack of consistency. But I think that this kind of research absolutely can be framed, and my committee would be happy to make this QC and not require consents. And if we're willing to do it, then I'll bet other people would be willing to do it, and we could apply social pressure and et cetera. So don't give up the fight. It just seems absurd to me, absurd to have consents for this kind of research.
Let me thank the panel once again, and next year we'll be reporting on the progress.